Good afternoon, everyone, and thank you so much for joining us today. Today is actually our 11th session in our first ever virtual Successful Aging Expo. So we just wanted to say thank you for joining us in the midst of the pandemic, and we expect to have a great webinar session today. So for starters, my name is Lindsay Haynes. I am the event manager with Prairie Mountain Media, and I'll be the moderator for today. I actually have the honor to let you know that we will have two presenters, both talking about different aspects of eye health. And so kind of how that looks is they'll each present for about 20 to 25 minutes, and then we will follow with question and answer, and then we'll wrap up around 1 o'clock. So you'll see at the bottom of your screen today that we'll have an active question and answer portion as well as a live chat that's going on. So especially today, because we'll see two different presentations, at any point you can go ahead and enter in any questions that you have, and then we'll make sure to address those at the end. We did want to remind everyone that this webinar is also being recorded, and so on our website you can rewatch this one, or you can visit their sponsor pages, or even see some webinars that we've had in the last couple weeks in regards to our Successful Aging Expo. So you can find that at www.timescall.com/aging. So today we have we'll get started with cataracts and glaucoma presented by Dr. Parikh, and then we'll follow with a webinar, age-related macular degeneration, presented by Dr. Manry, both from the Eye Care Center of Northern Colorado. So with that being said, we'll go ahead and get started, and I will turn it over to Dr. Parikh.
All right. Okay, so welcome everyone. Thanks for spending some time during your lunch to listen to some information about eye disease. My name is Mansi Parikh, as Lindsay mentioned. I am an ophthalmologist at the Eye Care Center of Northern Colorado. Let's see here. And just a little bit about me. I'm a board certified ophthalmologist and a glaucoma specialist. I've been in practice since 2009, and I've been here with the Eye Care Center since December of 2019, so almost a year. I grew up on the East Coast, and I went to school out in Philadelphia, and then I did some training out in Chicago, and I did my glaucoma training in Iowa. And I've moved around a little bit, but I'm settled here in Colorado and don't expect that I will be going anywhere from here. So I'm just gonna start with a brief overview of how the eye, sorry about that, how the eye processes light. So then we can talk about the different ways that you can develop problems with your vision. So the visual pathway is actually quite complicated. It is not only the eye that focuses light, but that light is processed and sent to the brain, and your brain is actually where the picture that you see is created. When you do look at light coming into the eye, initially light enters the eye through the cornea, which is the front clear dome in the front part of the eye. The cornea does focus the light partially. The light then passes through the pupil, and it passes through a lens, which is marked here. That lens focuses light onto the retina, which is the clear tissue on the back part of your eye. It's often referred to like a camera film. So the light is focused there on the retina. The retina processes the light and sends the signal through the optic nerve, and the optic nerve then continues back to the back of the brain. So basically, problems anywhere along this pathway can cause problems with vision, and depending on where the problem is, sometimes it can be treated. Certain conditions can't easily be treated. So here, one of the most common issues you can have are issues in the front of the eye, either with the cornea or the lens. If you have problems up here and they don't focus the light properly, that can be a reason for blurry vision. So I'm going to be talking about two different diseases. I'm going to be talking about cataracts and glaucoma, which are both very common causes of visual impairment. Worldwide, cataract is the leading cause of reversible blindness, and worldwide glaucoma is the leading cause of irreversible blindness. Both conditions are more common with age. So I'm going to just briefly talk about cataract first. Cataract is essentially a clouding of the natural lens. So again, if you remember that picture we were looking at, there's a lens in the front of the eye. It sits just right behind the pupil. We get a good view of the lens when someone has their eye dilated, as shown in this picture. This picture has an exaggerated cataract. Most people's eyes don't have a cataract that looks like this, but just for the purposes of being able to illustrate something, you can see in this gentleman's right eye, he has this white cloudy appearance, and the left side appears to be clear. So the natural lens in the eye, most people are born with a clear lens. And I like to tell people it's like having if you were to leave a bottle out in the sun for 10 years, it would turn yellow and become brittle. And the natural lens filters light your entire life, and eventually it becomes yellow, brittle, and it can become cloudy. When you develop a cataract, the things that most people will complain of are kind of a slow, progressive blurring of their vision. Most cataracts don't develop suddenly, so generally they do develop over time. If the lens is very cloudy, when light enters the lens, instead of focusing properly, it will scatter, which can cause a lot of glare. So specifically, sometimes people will complain of glare when they're driving at night, when bright lights are hitting their eye, the inability to see well because of the glare. And then also, as the cataracts get yellow over time, the more yellow they get, the less bright things will look. So people may notice having more trouble seeing in dark conditions. There's also a little bit of a difference in the way you perceive color, because it's like you're looking through a yellow filter. So for example, in this picture, if you were to look at the sky on the right side versus the left, which is the left side is like if you had a cataract, that sort of white looks more yellow. And so often people will notice when cataracts are removed that colors look very different after the lens is replaced with a clear lens. So cataract surgery is one of the most common surgeries performed. And thankfully, at this point, modern cataract surgery is quite a fast and safe procedure. In cataract surgery, what we do is essentially remove that cloudy lens. This is done with a surgery. It is not done with a laser procedure. And we do make a very small incision or cut in the cornea so that we're able to go into the front of the eye and remove the cataract. So we use some machines that help take the cataract out. And typically this procedure takes about 10 to 15 minutes to do. Once the cataract is removed, we place an implant in the eye. The implant is clear, and this implant is going to help focus the light onto the back of your eye. Without an implant, a person would have to wear very thick glasses. So we always put implants in the eye. Generally, like I mentioned, the procedure is quite fast, doesn't require general anesthesia. We are able to do it under a local anesthesia with just a little bit of medicine to help reduce anxiety. And for most people, the recovery is quite quick. One of the things we get asked about a lot are if the cataracts will grow back, and cataracts do not grow back. And lens implants that we place in the eye do not need to be removed or replaced at any point in the future. This lens implant that I mentioned is essentially a plastic material. It's a material that the body tolerates really well, so the body won't reject this implant. There are many different types of implants available to us out there. There are some specialty implants now that can be used to reduce astigmatism, so people can have better vision without glasses. There are multifocal lens implants that can, in some situations, help people see both far away and up close without glasses. And then there are the general lens implants, which are the ones that are generally covered by insurance. We determine what type of lens implant to place in the eye based on measurements we do. So usually you'll come into the office, you'll have a bunch of pictures taken of your eye that measure the shape of the eye. And using those measurements, we can determine what strength implant will best focus the light on the back of the eye. So I'm going to switch gears and spend most of my time now talking about glaucoma. And the first thing I want to mention is, although glaucoma sounds like a singular term, glaucoma is not a single disease. Glaucoma is a term that's used for a group of diseases that all affect the optic nerve. So again, if you remember back to what we're talking about, the visual pathway, light is focused onto the retina. The retina then sends a signal through the optic nerve back to your brain. So your optic nerve is a cable that connects your eye back to your brain. And if there is damage to the optic nerve, the signals don't make it back to the vision center. And you can have vision loss due to that. It's a very different type of vision loss than some of the vision loss caused by other eye diseases. Glaucoma is a chronic disease. So similar to something like diabetes, it's not something that we cure. It is an eye condition that we manage. And it is a progressive problem, but with proper management, it can progress extremely slowly so that there aren't hopefully problems that people have in their lifetime with their vision. So again, back to the optic nerve, I mentioned it is a cable that carries this vision. And if the optic nerve, for some reason, is not sending those signals back, you do lose vision from that. If the nerve is completely damaged, in a worst case scenario, a person can be blind from that. And at this point, the optic nerve is essentially a part of the brain. So it is a structure that does not regenerate on its own when it's damaged. And at this point, we don't have good treatments to regrow the optic nerve. So our goal always is to prevent problems that cause damage to the optic nerve. When we, as eye doctors, are looking into your eyes and we do a dilated eye exam, we can see the optic nerve head. The optic nerve head is a part of the optic nerve that enters the back part of the eye. So this is a picture of the optic nerve head. And one of the things I want to point out, the optic nerve is this round structure here. There are blood vessels that come out of the optic nerve, but the nerve itself is this kind of round structure. And you can see if you look at this picture that there is this kind of orangish red arc that goes around the edge of the optic nerve. That area is called the rim. The rim is actually the fibers of the optic nerve, and these fibers come from the retina. And in the center of the part of the optic nerve, there's this lighter colored area that we use the term the optic nerve cup for. The cup is basically an area where there are no fibers. And in different people's eyes, there will be variances in the way the rim looks and how large the cup is. But what happens in glaucoma is that regardless of what shape the nerve was at its start, the rim, which is the outer tissue, becomes thin and damaged over time. As that tissue thins, it looks like the cup, which is the area where there's no tissue, gets larger. So you can see between the left here and the right, these arrows are pointing out the shape of the cup. So this is quite a large cup, and there's a very thin rim. And glaucoma is really one of the few eye diseases that causes, quote, cupping or enlargement of the cup over time. It tends to cause this cupping in certain patterns. So the top and the bottom part of the nerve are often the areas of the rim that thin first. So often we will see this vertical elongation of the rim. And while there are different size cups in different people, some people have larger cups than others, the loss of rim tissue or the absence of rim tissue in any particular area is not normal. And so in those situations, we can diagnose glaucoma, sometimes just based solely on an exam. When the optic nerve becomes damaged, early on, you may notice no symptoms or problems at all. But over time, one of the things the nerve damage does is cause some changes in the peripheral vision. This is always something I want to talk about because people often think of peripheral vision as your vision out by your ears. And and they think of glaucoma as tunnel vision that starts to come in this way towards the middle. However, that is really not the way that glaucoma tends to affect vision early on. Most people tend to develop some problems in their peripheral vision actually in and towards their nose. And those are areas that you don't notice when you're just walking around, especially if it's affecting one eye. Your other eye will often fill that in. And until you develop a blind spot, which takes quite a lot of damage, you may not notice this at all. So we do these tests called visual fields that help us determine whether there are any changes in the peripheral vision. So this middle slide is showing just some early changes towards the nose. And then as glaucoma gets worse, it will progress from the nose over towards the middle. And in very, very advanced glaucoma, it becomes a complete blind spot. And at that point, people will become aware of that issue. So who gets glaucoma? In theory, anyone can get glaucoma. So babies can be born with glaucoma, children can get glaucoma, teenagers can get glaucoma. Young adults can get glaucoma as well. So anyone can get it. However, it is more prevalent as people age. So most of the time, most people with glaucoma, vast majority will be over the age of 60. It's estimated that about 3% of the population will develop glaucoma. And just to review a few of the risk factors, like I mentioned, it is more common over the age of 60. There are some differences based on race. So African Americans often develop glaucoma at younger ages and they have more severe disease. In African Americans, glaucoma can develop in the 30s or 40s, so much different. And those of Hispanic background also tend to get glaucoma at higher rates, although they tend to develop it when they're older. If you have a family history of glaucoma, then you are more likely to develop glaucoma. If you have a parent or a sibling that has glaucoma, you're at a 10 times higher rate of potentially developing glaucoma. So if glaucoma is in your family, it should be something that your eye doctor is aware of, and you should have routine exams just to screen and make sure you're not developing any signs of this. And finally, high eye pressure. So a lot of people think of glaucoma as high eye pressure, and that is not exactly true. The higher the eye pressure, the higher the risk that you will develop glaucoma. However, it is possible to develop glaucoma at a normal pressure. And some people with high eye pressure don't develop glaucoma, which again, glaucoma means damage to the optic nerve. So it is a risk factor, and we are always paying attention to eye pressure. However, eye pressure alone doesn't diagnose this disease. So if you were to be sent for tests for glaucoma, just some things that you might encounter in your exam. First is a visual field test. A visual field test, again, is a peripheral vision test. You sit in a machine like this, and there are lights that are projected, and you push a button when you see the light. It helps us determine whether or not there are any changes in a person's peripheral vision that potentially could be due to glaucoma. One of the other tests we do is something called an OCT. With technology, we've come really a long way from what we were able to see before. We now have these machines that are able to take these very detailed pictures of the tissue in the back of the eye. And an OCT can measure the actual thickness of the optic nerve. Like I mentioned, as the nerve becomes damaged, it becomes thinner. So we're able to take these measurements, determine if the thickness of the nerve is normal. And we can also follow these tests over time to see if the nerve is getting progressively thinner over time. So glaucoma treatment in general is focused on lowering the eye pressure. There are many very, very large studies that have proven that if you lower the eye pressure, you can slow down the progression of this disease, or in other words, slow down the ongoing damage to the optic nerve. We can decrease eye pressure in a couple of different ways. We can either decrease the amount of fluid that the eye is making, or we can try to improve the outflow of fluid out through a drain that's inside the eye. So typically we start with eye drops. Eye drops generally are decreasing the amount of fluid being made. There is one eye drop out there that can improve some drainage, but generally it's focused on decreasing the amount of fluid made. And then there are lasers and surgeries, most of which are aimed at improving drainage. So with eye drops, there's really many different types of drops available out there. They range from being used once a day to up to 3 times a day, and they have different side effect profiles. Sometimes we use eye drops in combination with each other. And if at any point you do need eye drops, your doctor will talk to you about the potential side effects of the eye drops that they are prescribing. Laser treatment is something that is generally performed in the office. It's a treatment done to the drain itself to try to basically unclog the drain. It's generally a pretty quick and safe procedure where some numbing drops are placed in the eye, a contact lens is placed on the eye so we can see the drain, and it takes about 5 minutes or so to apply a laser. The effect of the laser takes about 4 to 6 weeks really to reach its maximal effect. And so if you were ever to have this type of laser treatment done, we would see people back a month and a half later to see how well it worked. And then lastly, there are surgeries. I don't want to spend too much time on this. It's quite complicated. There are many different types of surgeries. This is just a picture showing 4 different types of stents that are available that can be placed into the drain of the eye to try to improve drainage. And then besides that, there are surgeries that will completely bypass the drain if the drain is not working well. There are surgeries. The first one is called a trabeculectomy listed here, and then there's a tube shunt at the bottom, which is an implant placed. But both of these, again, are bypassing the natural drain and shunting the fluid elsewhere. So just real quick, the key points I want to point out about glaucoma is that, again, glaucoma is a disease of the optic nerve. That is the most important thing to remember about this if you're trying to remember something from this talk. The optic nerve is tissue that becomes damaged from this disease that that damage cannot be undone. So any changes that occur from glaucoma are unfortunately irreversible. And because of that, it's very important for this condition to be hopefully found early on exam and treated before there's a significant amount of damage causing problems. In anybody where we see any type of suspicion for glaucoma or definite signs of glaucoma, we'll be monitoring them with different tests to see how well our treatments are working. And because this is a chronic disease, treatment is lifelong. Luckily, most people in this country with glaucoma don't go blind from it, because if we are able to catch it early before the significant damage has occurred, we generally do have enough treatments to prevent vision loss in both eyes. And so just a couple of overarching points. There are multiple problems out there that can cause blurry vision and are more common with age. And a lot of times, I think people think of cataracts first because of how common they are. And often cataracts are the issue, but there are other eye diseases out there besides cataracts. And if you're having any type of trouble, you do want to make sure you have a full exam to see what's going on and if there's something going on besides cataracts. Cataracts, thankfully, can be fixed quite easily with surgery. However, some of these other diseases, the treatment is not so straightforward. And so always early detection is the most important thing to having good treatment and maintaining good vision throughout your life. And for that reason, it is always a great idea to have a routine eye exam, just like you would have a routine physical exam. So I'm going to have Dr. Manry is going to be talking about macular degeneration, and then I'm happy to answer questions after he speaks. This is just our offices. We have several offices in the area, and we are happy to see anyone at any time for concerns or for general eye exams. Thank you very much.
All right. I think hopefully everyone can see and hear me now. Just getting things set up for me. So I'm Dr. Matthew Manry. I'm one of our retina specialists at the Eye Care Center of Northern Colorado, board certified ophthalmologist. So I'll go through a few of these a little bit quickly since Dr. Parikh covered a lot of it, but we'll focus on what is macular degeneration and how is it treated for the most part. So as I said, I'm a board certified ophthalmologist, and I did additional training in medical and surgical retina care. I joined the practice just now over 2 years ago. I've been very happy here since. Originally from Philadelphia, but consider myself a Floridian originally, having gone to most of my school in Florida before residency at the University of Michigan. And then, like I said, additional retina fellowship at the University of Cincinnati. As Dr. Parikh said, we do comprehensive eye care in the community, and I focus on the retina care. So that's going to be things like diabetic eye disease, macular degeneration, retinal detachments, retinal tears, macular holes, things like that are what I will typically cover. Our 3 main offices within the Boulder County area, the main office is in Longmont, and then we also have an office in Greeley that we go to. And appointments can be made either over the phone or through our website as well. We also have a surgery center that opened a couple years ago and has our own dedicated operating rooms for eyes that we do the majority of our surgical cases at. As Dr. Parikh mentioned, this is kind of a diagram mock-up of the eye. The macula and the fovea are the parts of the vision that we'll focus on today. That's in the very center of the retina. And that's really what lets you see clearly is the fovea and the macula. That has the majority of your cones and the ability to detect good clear vision for reading and things like that. The further out portions of the retina are more peripheral vision. And so that does things like out in the periphery of what you're trying to see, and also dim light conditions. If the eye is like the camera, the lens of the eye is like the lens of the camera and forms a cataract over time. The retina is like the film of the camera to take the picture. And then the optic nerve is like the connection from the camera to your computer to review those images. Here's just an example photograph of the retina. You can see here, this is an optic nerve. And then these smaller vessels are the arteries, which are supplying blood to the retina. These larger, darker vessels here are veins. So they're taking blood away from the eye and away from the retina. As we focus on age-related macular degeneration, it's one of the leading causes of severe vision loss in people age 65 and older. It's not a part of the natural aging process, but is abnormal aging of the eye. It will often be symptomatic in both eyes, but doesn't always need to be both eyes. Sometimes one eye will be significantly more symptomatic than the other. And typically early on, most people actually really won't have much of any symptoms. And it's a little bit often more of what we'll see on our eye exam that might pick up on some of the early changes that key us into what to look for. In terms of the prevalence rates of how many people will have macular degeneration, it does go up over time to become more and more prevalent as people get older. And it's typically unusual to see it before age 60. Macular degeneration causes an area of vision, typically right where you're looking at, to disappear. So whatever you're trying to see is almost like a dark black spot wherever you're trying to look. When we look at things that are risk factors for developing macular degeneration with time, we look at older age. I discussed a family history of macular degeneration, just like a family history of glaucoma is a risk factor in terms of increasing the possibility that someone might have AMD, as we'll call it. Tobacco use and cigarette smoking is a significant risk factor for the development and the progression of macular degeneration, in particular wet macular degeneration, which we'll discuss in more detail in a little bit. And from a dietary standpoint, having low concentrations of antioxidants, vitamins, zinc, and other minerals. Possible but less certain risk factors would be female sex, lightly colored eyes like blue or green colored eyes, cardiovascular disease, obesity, high cholesterol, high blood pressure, and increased sun exposure. One of the questions that we'll usually get is my macular degeneration associated with cataracts or cataract surgery, or can those things make my macular degeneration worse? And the answer is no. This has been studied and is not associated with cataract surgery. And oftentimes we'll find that cataract surgery is a pretty good benefit to people. So when someone undergoes cataract surgery, they'll usually be able to see better, have better contrast, better ability to see and read. As I discussed, macular degeneration is typically an area that's blurred or sometimes missing when you're trying to look at directly at something in the very center of your vision. But it can also be distortion. So as you see some examples here where things are distorted or missing, and then on the right side of your screen is a standard, what we call an Amsler grid. It's a box with very straight lines, and on the right, there's a distortion of that grid. Now, there's a multitude of conditions that can do something like this. Macular degeneration is just one of them. But as a general rule of thumb, if you were to see some distortion like this, you should be seen for an eye exam to figure out what's causing it. When it comes to what to expect coming in for an exam for macular degeneration, in addition to checking vision, checking eye pressure, typically your eyes will be dilated. We will often be taking photographs of the eye. There are certain photographs that can give us more information sometimes than just looking. So here is an example of the macula. And in the macula, we see deposits of drusen. Drusen are abnormal byproducts of the photosensing cycle of the eye. And the accumulation of this material in the macula is damaging to the macula and causes stress to the cells and decreased function and death of cells. An OCT is kind of like a cross-sectional image of the retina. We see an example of it here. So the layers right here that I'm trying to highlight are the retina, and then beneath it are these drusen type deposits that you can see on the photos. And then another thing that we'll often do are a test called an angiogram. We inject a dye through a vein in the arm, and we watch blood flow through the eye, and we can see areas of abnormal blood flow here in the macula that can indicate certain types or amounts of macular degeneration. The most prevalent and common type is the dry macular degeneration. That can progress over time, and at the late stage, it forms what we call geographic atrophy, or GA, so literal patches of the retina that have died off and are no longer even present or functioning because of the macular degeneration. And then a smaller subtype, as you see here, is wet macular degeneration, and we'll talk more about that in a second as well too. Dry macular degeneration is the most common form. Vision loss is typically very gradual. Some people often early on are asymptomatic and will come with a extremely slow or gradual decline with time. And it's hard to predict exactly what that rate would be. As these areas kind of convalesce and come together, then patches of atrophy can form, which impact the vision negatively. As you see here, here's an example of atrophy with vessels that are beneath the retina. So this is portions of the retina which are no longer present, and we can see here the blood vessels in what we call the choroid, which is beneath the retina. When it comes to treating dry macular degeneration, vitamin supplements are really kind of our mainstay at this point. As they've looked and done extensive studies to look for things that would work in dry macular degeneration, supportive health with good nutrition is one of the main factors. So vitamin C and E, the antioxidants lutein and zeaxanthin, which we'll sometimes find freestanding, zinc and copper, and that's typically in combination with a standard daily multivitamin, and those two are taken together to promote macular health. There are other brands that are out there, and a lot of them will provide macular support. But in general, you want to make sure that they contain at least the AREDS2 type amount. So at a bare minimum, it should be something that contains this quantity of vitamins and minerals. As I discussed, a healthy diet is definitely helpful, kind of a Mediterranean diet. A lot of olive oil and fish, a little bit of red wine, probably helpful. And green leafy vegetables are helpful there. Avoiding tobacco products is a big key when it comes to risk factors of going from the dry to the wet form of macular degeneration. Tobacco products greatly increase the risk that this might go from the dry to the wet form of macular degeneration. The Amsler grid we discussed a little bit earlier. Here you can see some of the distortion on that grid. And so there's a device at home called the 4C Home Monitor that allows you to kind of test almost like a grid at home, and kind of click where areas may appear straight or wavy. And based on your information on the machine, they may say, oh, we've got some concerning findings. You actually probably need to get in to see your doctor for an evaluation. And these are typically devices that patients will use at home who have already been diagnosed with macular degeneration. When it comes to potential vision loss associated with the dry macular degeneration or wet macular degeneration, there are low vision specialists who can help people make the most of the vision that they have. Things like visual rehabilitation, adaptive technology, orientation to things in the home, trying to make it a little bit easier to get around if you're having a hard time seeing, and different magnifiers and light aids. When it comes to things in the future, there's a lot of things that are always in study, and multiple drugs are in clinical trials. They've looked at different eye drops, oral medications, and medications that go in the eye, along with gene therapy or stem cell treatments to find things that work. And unfortunately, at this point, there's a lot of things that aren't quite working. So we're still working on clinical trials to find things that might make a difference. I think we're hopeful for things in the future, but we don't have a lot in our armamentarium for dry macular degeneration. Wet macular degeneration, we can treat a little bit more effectively, but is a bit of a different animal. It's caused by abnormal blood vessels that grow beneath the retina. They can then leak blood or other fluid, which can cause a much more rapid and severe decline of vision. 10% of macular degeneration patients will go from the dry to the wet form. And if people have wet macular degeneration in one eye, there's roughly a 35 to 40% chance that wet macular degeneration may form in the other eye. So we tend to keep a close watch on those patients. As you can see here on the example image of an OCT, this is a fairly normal image on this side. And this side has this net of abnormal blood vessels here that we call a choroidal neovascular membrane, with a pocket of fluid on each side. When it comes to treatment of these, this used to be the mainstay of treatment was thermal laser, and that was before we had effective drugs, basically using laser beams of energy to destroy the abnormal areas of blood vessel, rarely if ever used at this point anymore. The mainstay of treatment is injections of medications called anti-VEGF, vascular endothelial growth factor, which takes and tries to take these blood vessels that are abnormal and works to kind of shrivel them up and shrink them so that they're not leaking anymore. Most people will maintain the vision that they have if we get them on effective treatments, and some people will get better vision and improvement in their vision by being treated with these medications. There are currently 4 different treatments that are out on the market that are more typically used. Another type of treatment is photodynamic therapy, which is kind of like a laser treatment, but more of what we call a cold laser that's based on a medicine that is activated by light. We use this in selective cases for the treatment of wet macular degeneration that can be discussed further with your retina doctor. Sometimes surgery is needed. If there's a large area of bleeding from the macular degeneration, then we may go in and do a treatment to try to remove or displace the blood of the eye. But that's reserved typically for the more severe cases. Some of the questions that are often asked are, which medication should we start with? How often do we need to do these treatments? How long do I need to do the treatments? And obviously, does the injection in the eye hurt, and what can I expect? So the medication, which medication is started is kind of up to a conversation between you and your retina specialist, who's typically going to be treating these diseases. I usually start with the medication called Avastin, which is kind of a generic medication that's very effective and works very well, and is also very cost effective in terms of treatment. If those medications aren't quite working as well as we'd like them to, there are other medications that can be more effective and are stronger, so they may work better if Avastin's not quite cutting it, but they are of higher cost, so we have to kind of have a discussion about that as well. How often do I need the medication? Quite often, at least initially, people are getting a treatment about every month. And then depending on the results of the treatment, you may get an as needed protocol where we only inject if we're seeing activity. Or another approach is to go longer and longer between injections, as far as maybe 3 months between each injection, and see if that keeps things kind of inactivated and quiet as well. Most people are going to need to be on these medications for the duration of the disease. There are some patients who can extend out and get off treatments so that they no longer need injections or only need them very rarely. But that's probably the exception rather than the rule. As we look at most people, they are typically going to need maybe 6 or 7 injections on average a year. From a standpoint of what to expect with the treatment, we numb up the eye typically very well. So you're not going to see a needle coming right at your eye, kind of are looking away a little bit. And typically patients are going to feel either nothing, maybe a little pressure, a pinch for a split second. We use a cleaning agent called betadine that can sometimes irritate the eye, which is rinsed out afterwards. And that can cause a temporary burning and stinging after the injection. When it comes to future treatments, we're also looking at treatments that are either oral or eye drops, and different injections that are in clinical trials at the moment. We're looking at drugs that are longer lasting, so they don't have to be treated as often, and new targets for treatment. Instead of anti-VEGF, we're looking at different targets such as Ang2 pathways or the complement pathway that will work to try to stop progression. The port delivery system is a device that is currently still in trials and may be perhaps available on the market as soon as next year, but is surgically implanted in the eye and has a reservoir of medication to control the macular degeneration, which is continuously transmitted into the eye. When the reservoir is emptying or nearing emptying, then it can just be refilled in clinic, and in studies could last as long as a year or a year and a half between some refills. We're also looking at gene therapy, so looking to inject the signal of the drug into an eye so that the eye can make and manufacture the anti-VEGF drug itself, so that they don't continuously need injections. So those are our kind of current and future directions for treatments. It's a hard disease sometimes to deal with, but you know, like I said, we're working to get better treatments and working as best we can to preserve someone's vision over time. So that will conclude my presentation portion.
Great. Thank you so much to both of you for your presentations today. We did have a couple questions that came in during the webinar, so I did want to go ahead and get started with Dr. Manry. This first question's for you, and the age-related eye disease study vitamins and specifics. Do those help prevent age-related macular degeneration?
Yes, that is a great question. That is one of the things that has been studied, is if you have a family history of macular degeneration or you're just working to avoid it, are those vitamins of any benefit? And what they found in studies is that really the only benefit is seen if someone has moderate stage macular degeneration or worse. So if you have no evidence of macular degeneration, or if you only have a family history, or if you have the very early mild forms, then typically taking the AREDS2 vitamins will not be of any benefit in terms of reducing the fact that it could present itself.
Our next question came in, and so I'm just going to kind of read it word for word so I don't mess up or misinterpret their question. So my vision is good, but my eye health professional says I have early signs of age-related macular degeneration. So what exactly does that mean?
So the early signs of age-related macular degeneration are typically that we are seeing some drusen within the retina. Now, drusen can be a just a feature of aging of the eye when they're very small and there's only maybe one or two or a handful of those. But as they become more numerous or as they increase in size, then we consider that a shift from the just standard age-related drusen to the more potentially troublesome drusen. And so it's really when it goes from the early form to more of the moderate form that we start to kind of address things more, shorten treatment intervals, look at putting someone on the AREDS2 eye vitamins, things like that.
Okay. So is there ever a situation where, you know, you see those early signs, but you wait and you have them come back, you know, before you move forward with anything like that? Or do you
Correct. Yeah. So there will be a lot of patients where they just have maybe one or two drusen and they're completely asymptomatic, and they might just be seen once a year, and throughout their whole life, those one or two drusen may never progress. And so it's only if we're kind of seeing progression over time and if we're starting to see it cross certain thresholds that perhaps then we encourage more intervention.
Great. Thank you. So our next question is for Dr. Parikh, and this one specifically is in relation to actually glaucoma with cataracts. So this question, how does cataract surgery affect glaucoma in a patient, or does it at all?
Okay, yeah, that's a great question. It's not a totally straightforward answer. You know, part of what I'd mentioned is that the term glaucoma really encompasses a host of different diseases. So there are different types of glaucoma. Cataracts, so both cataracts and glaucoma are more common as a person ages. One does not cause the other. In some types of glaucoma, cataract removal can actually help the glaucoma control. So in certain types of glaucoma, removing the cataract can help reduce the eye pressure and make people slightly less dependent. Most people who don't have end-stage glaucoma, if they have cataracts and the cataracts are removed, they will see better even though they have glaucoma as well, unless you have really terrible nerve damage, which is the sole reason that you can't see. Often people do have some improvement with cataract removal. And then there's the part that if you happen to have glaucoma and you have a cataract and you need the cataract removed, there are some procedures sometimes that can be done that are considered minimally invasive. We use this term MIGS, that can be combined with cataract surgery. So at the time of the cataract surgery, a stent could be placed or something could be done to try to improve the glaucoma control. So there's a whole kind of fork of pathways if you have these two, and part of it depends on what type of glaucoma you have.
Great. So when you also kind of touched a little bit on cataract surgery, my question that kind of came up is if you had previously like a laser eye surgery to, you know, give you that 20/20 vision, does a cataract surgery then affect that or change it or anything like that?
So typically when a person has had a laser procedure, so LASIK, most typically LASIK.
Yeah, like LASIK, yeah.
What they've done is they have changed the shape of the cornea. So that's the very front part of the eye, so that the light is focused properly. Once you have a cloudy lens in your eye, that light is not going to be focused properly anymore. So while I would say cataract surgery doesn't go back and affect the LASIK that was previously done, if you've had LASIK done, that affects how we determine what type of lens implant to put in the eye at the time of cataract surgery. So we do take a bunch of measurements of the eye and we use these mathematical formulas to determine what type of implant to put in the eye. Anyone who's had a surgery to the cornea, that previous surgery can make some of our measurements inaccurate. So sometimes there's a little bit more, it's not a huge amount, but a little bit more error built into how good we are at predicting what type of implant will really get you that good 20/20 vision if you've had prior LASIK.
Okay, great. Okay, so we did have another question that came in, and since we do have two doctors from the Eye Care Center, either of you can answer this one, but how does diabetes affect vision?
I'll take a swing at that one since diabetes mostly affects the retina. So diabetes can do a multitude of things. As someone's blood sugar is fluctuating, sometimes you'll find that there are some changes to the lens of the eye. So if you have kind of a standard, prescription or ability to focus, if your blood sugars swing wildly high or low, then it can take the image out of focus. And so that's sometimes some diabetic signs that their blood sugars are out of whack is they say, oh, my vision's blurry, so I know my sugars must be, too high or too low, and they'll check it. Diabetes can cause cataracts to form at an earlier age. So instead of cataract surgery in, say, age 60 or 70, maybe you're needing cataract surgery in your 50s or sometimes even in your 40s. When it comes to diabetes and the eye, the mainstay of the vision impacts are typically in the retina. So diabetes causes damage to blood vessels and inflammation within the blood vessels and within the eye. And that causes areas of bleeding, and blood vessels that usually would not leak fluid then start to leak fluid or other proteins in the eye. So it can cause swelling within the macula and also new blood vessel growth within the retina to counteract that. And you would think, oh, these new blood vessels are great because they're helping get more blood flow to the eye. But unfortunately, these new blood vessels are very fragile and they're growing in an area that they're not supposed to grow. And so they'll quite often bleed into the eye, and they can cause traction and pull and even detach the retina. And that's something that we'll sometimes need to treat with lasers, injections, or surgery.
So kind of going off of that, I do know somebody that has type 1, but they are relatively younger. She's actually in her 20s. So for right now, for example, does she need to just continue to do her once a year checkups, and it's kind of more important as she ages? Or what do you think about that?
Yeah, that's a really great question. When we look at people who've just been diagnosed with diabetes, typically they'll do an eye exam around the time of the diagnosis to see if there's findings within the eyes. And then at a minimum, a patient who's a diabetic needs to get an eye exam once a year. So you need at least an annual checkup to look for things. Over time, the longer and longer you have diabetes, the higher the chances that we'll start to see some changes in what we call diabetic retinopathy. If we're starting to see changes that are getting severe enough, we may shorten that follow-up to every 6 months or every 3 months or every month, depending on what's going on, to determine if and when we need to treat to try to save or improve someone's vision. Another big factor that plays into that is how well controlled your diabetes is. So, if you're diabetic and you're a very well controlled diabetic, then, you are probably fine with the once a year exams. But if your diabetes is poorly controlled, if your hemoglobin A1C is, say, 11 or 12, things like that, then you might be in trouble, and we might have to kind of keep a closer check on you.
Okay, great. So this one will go back to Dr. Parikh. I have had LASIK surgery 20 years ago. So I'm still good, but I'm developing a cataract. So I was told the surgery to remove the cataract is different. So what exactly is different?
So the procedure itself is typically not different. The actual steps that are done to remove the cataract surgery are pretty standard, whether or not you've had LASIK. If a person has, this is a LASIK question, but if a person has had RK, which is a slightly different type of procedure that used to be done, radial keratotomy, that is a slightly different procedure that was done. And sometimes you do have to make some adjustments in the way the surgery is done. LASIK, typically it's about the same, but we do have to be very careful with the calculations for what type of lens implant we put in the eye. So like I mentioned, we can have some errors with that. We often will use 3 or 4 different types of formulas, take an average of what we're finding between the formulas to do our best to get the result that we want afterwards. I always tell people who have had refractive surgery, often a person who has had refractive surgery was used to being 20/20, and they will want that same outcome with cataract surgery. And sometimes we don't have that same precision with our lens implant. So some people may need to have some laser done after the cataract surgery as sometimes the term is used, an enhancement to reduce if there's a little astigmatism or something left over after the cataract surgery.
Great. So this next question is for both of you as well. I know, Dr. Manry, you talked a little bit about a healthy diet and how you can kind of prevent the macular degeneration, but are there any supplements that are shown to be preventative for both, cataracts, glaucoma, and age macular degeneration?
I can say from a glaucoma perspective, the short answer would be no. Just like the retina, the optic nerve and the retina, these are all nerve tissues. Nerve tissues in general are very sensitive to blood flow. So any dietary, anything in your diet that is good to maintain blood flow, maintain blood pressure at a normal level, will typically be good for the eye. So he mentioned green leafy vegetables. That's also something that is good from a glaucoma perspective, helps maintain good optic nerve blood flow. So from that perspective, there's those things. There are not supplements out there that reduce eye pressure. There are some supplements out there that people question may help protect the optic nerve. And the term that's used is neuroprotective. And I would say that the evidence out there is mixed about a lot of those supplements. I don't think there's anything really used as a standard supplemental treatment. But some people will use some things like, for example, ginkgo, bilberry. So there's a few things out there. Again, they are not treatments for the disease or preventative.
Awesome. And then same thing, are there any supplements shown to be preventative for the age-related macular degeneration?
No other supplements that are preventative. Yeah, there's not anything that I could point a finger at that are preventative for that. When it comes to supplements in the eyes and things that we'll generally recommend, in terms of, say, cataracts, I think a part of that, or a lot of that, is also things like UV light exposure. So living in Colorado, which is a very sunny state, you want to have a nice set of UV blocking sunglasses on to kind of reduce progression of the cataracts, and trying to eat a good, well-balanced diet. Omega-3 fatty acids or fish oil can be helpful in terms of dry eye. So that can reduce dry eye symptoms in people. And Colorado is a very dry eye state, so that is usually a supplement that I will recommend to patients. And then, a multivitamin is probably a good idea from an eye standpoint, just to promote overall good blood flow, like Dr. Parikh was saying, et cetera. But I would usually reserve the macular health or ARIDS 2 vitamins for people who have more diagnosed disease.
Great. So it looks like we don't have any other questions, and you answered all of the ones that I had as well. So I just wanted to say thank you again for your presentation and your time today. For our viewers, both doctors did have a couple of resources and the ways that you can kind of either schedule an appointment or where you can visit their offices. So like I said at the very beginning, this webinar is being recorded, and you will be able to view it again on our website, www.timescall.com/aging. So thank you again, and thank you everyone for your time and joining us for our lunchtime webinar series.